Today in this couple of videos we're going to have a look at the pathology of the periapical tissues. Now this is going to build on what we've been looking at in terms of the pathology of the pulp, and it is the next logical step beyond that. The aims and objectives, as you can see here, are the things that we're going to cover, but also the number of items that we think you should be aware of, particularly the range of lesions and a number of specific lesions such as periapical granulomas and a radicular cyst. Now if we go back to have a look at the anatomy of this area, you can see what we're looking at in the radiograph is a periapical radiograph and about the premolar region, and you can see the tooth that looks relatively intact, and also associated with that is the lamina dura, which is the white space which outlines the periodontal ligament, and then the periodontal ligament itself, which sits between the lamina dura and the cementum of the root. Now that's got a histological correlate, as you can see in the small inset histology. And this is the sort of tissues that we're looking at. And you have a look at the right side of the picture. You're looking at alveolar bone. It's got incremental lines, it's got osteocytes and so on. And then on the left-hand side, there is the cementum, and then underlying that is dentine. And so the periodontal ligament itself runs between the cementum and the bone with the insertion of fibers into both ends. Fibers run across. There's obviously vasculature, as you can see there's dilated blood vessels here as well. When you have a look at this histology under polarized light, you begin to see some idea of the detail that's going on here. And when you have a look at these fibers as they insert into the bone in the periodontal ligament at higher power here, you can see that the fibers which are inserting into the bone, these individual collagen fibers, and they're anchoring the tooth into the jaws. Also associated with this is epithelial remnants. These are the remnants of the root sheath of Hartwig, which is responsible for the formation of the root of the tooth. When it breaks down after root formation is complete, most of it disappears, but some small remnants, as you can see in the picture, those little floretive epithelial cells, they are termed the cell rests of Malassez, and they are quite common in the periodontal ligament, and they are significant for reasons that I'm going to come to, because they are the source of the epithelium which lines the radicular cyst, the inflammatory cyst, which is related to a non-vital tooth. So now we come to periapical pathology. And the main condition that I'm going to talk about, which I will do in this video, is periapical periodontitis, which is inflammatory disease of the periapical space. The second shorter video will cover the other pathological processes, such as reactive pathologies and neoplastic. So what about periapical periodontitis? So periapical periodontitis arises as a consequence of pulp pathology. Now, as we saw when we had a look at pulpitis, pulp death is almost always due to caries, but there are other reasons for it. You can have a direct blow to a tooth, which damages the blood supply, and you end up with hypoxia and pulp death in relation to that. But it is far more common for periapical periodontitis to be a consequence of pulp death following pulpitis from caries. So this brings us to the etiology, which is largely as infective and from the root canal in a patient who has had dental caries, which has resulted in pulp death. The bacteria from the carious lesion extend and they grow in the pulp chamber and then extend to the whole of the root canal system and then to the apex. And then inflammatory mediators and the bacteria themselves can then extend into the periapical space, causing periapical periodontitis. There are other routes of being able to get bacteria into that space, and particularly if a patient has periodontal disease, a perioendo lesion so-called, that pocket extends down effectively to the apex of the root. You can get bacteria extending into the periapical space due to periodontal disease. There are a number of traumatic etiologies. Some of these we've mentioned, for example, the physical one of a direct blow to the tooth. But the others are other possibilities of direct physical trauma to a tooth. For example, if you, on restoring a tooth, happen to leave a filling which is high in the occlusion, which means that that particular tooth will be bearing a load of the occlusion, well then that can also result in periapical periodontitis. Patients who have malocclusions or who brux, that is, they grind their teeth, can also put excessive loading onto particular teeth, and the result can be periapical periodontitis. There are a number of other causes, chemical and mechanical, which are related to operative dentistry. Chemical can be via the root canal system, so that's root canal medications. In times past, there used to be some very nasty chemicals which are used in endodontics, which you really do not want to get out of the apex into the periapical tissues, and sometimes it did with rather spectacular effects. So you still do have to be careful in using root canal medicaments that you do not end up with a huge amount of chemical that you're using through the apex of the root. And then there's just pure mechanical trauma when you're instrumenting a root canal, that you might inadvertently pass the file through the apex and take with it some infected material, which can cause that, or even just the trauma of putting a file through the root will damage the periodontal ligament in that area, again causing periapical periodontitis. And in fact, it's relatively common, and it's something that you very often say to patients who are undergoing endodontics, that the tooth will be a little bit tender to touch, tender to percuss for a few days after having endodontic treatment. So what is the natural history of this? Well, it can be quite complex. At its most basic, we have symptomatic or acute periapical periodontitis and asymptomatic or chronic periapical periodontitis. Now, as with all these things, what you actually get clinically in a patient is a balance between host factors and the bacterial factors, and everything is held in a balance, and it may be that balance tips towards the patient having a symptomatic periapical periodontitis, which may resolve to or settle down to a chronic periapical periodontitis, but that can have later flare-ups and go back to an acute periapical periodontitis. So there is a way in which you can move between the acute and chronic forms of this, and that's what happens for many patients. And so when you have a look, again, that possibility of moving between these forms in terms of an abscess could form, which could settle down to chronic periapical periodontitis, and so on. These makes for quite a complex interaction, but we are actually going to separate them off into, well, what happens following through the acute side of things, and then we'll separate the chronic side and have a look at that separately. But please do remember, when we are dealing with them separately, that there is a point where chronic lesions can flare up to acute lesions, and acute lesions can settle down to chronic lesions, and so on. So what about the symptomatic or acute periapical periodontitis? Well, initially, the inflammation is confined to the periapical space. So that's just the small area of the periodontal ligament, which is around the apical opening of the root canal system. The pain, once it spreads into that area, becomes much more localizable. We have said in the pulpitis lecture that at times the pain of pulpitis can be really poorly localizable, and the patient can have difficulty highlighting exactly which tooth it is that is painful. Whereas with periapical periodontitis, that's not the case. There are more proprioceptive fibers, and so the tooth can be really quite accurately localized because it is tender to touch. Because of the inflammatory infiltrate, the tooth can be a little elevated in the socket, and of course that makes things worse because it makes it proud in the occlusion and have a greater tendency to have further trauma. At this very early stage, there can be very little radiographic change. There might be a little bit of loss of definition of the lamina dura if this has been present for a little while, but very often you get really little change. And of course, these can be transient or persistent depending on the cause. If it's just a single blow to a tooth, it may resolve and really be nothing further. But if it's related to caries and pulpitis pulp death and the necrotic pulp is still in place, well then there's a continual drive to periapical periodontitis, and it can be persistent. The next step in that is to progress to an abscess which is present in the periapical tissues, and we call this an acute periapical abscess. This, as an abscess, contains lots of neutrophils. That's the definition of an abscess, a collection of dead and dying neutrophils. It contains pus. But the bacteria tend to be mixed anaerobes because of the bacteria which are present within either the root canal or sometimes in the periapex, and more often actually within the apical area of the root canal, because that's almost protected from a lot of the effects of the inflammatory system. And so that primary abscess can be localized just to the periodontal ligament space, but now you do begin to get to see changes. The periodontal ligament space will be widened, and there will be clear loss of definition of the lamina dura just in that particular area. Again, if that is not stopped, or you can then get that extending, and the pus which has been formed in the periapical abscess can begin to spread. And so initially it's just going to spread in the immediate area. So for example, it will spread in the periodontal ligament, and if the canal system is open, for example, if there's a cavity which allows pus to drain, it will also drain through the tooth. Sometimes later on, if the abscess has been present for a long time, it can drain through bone, and we get what is formed a sinus, and that is a point where pus will drain from an internal structure onto the surface. What you actually get in terms of the direction in which pus tracks is determined by a number of different things. The important thing is that it will always spread along the path of least resistance, so it will go the easiest way. And the anatomy of the area does dictate quite a lot of what happens. Remember, within the maxilla, you may have the maxillary antrum, and in fact that can be very close to the apex of some of the upper molars. You will have muscle attachments, which determine where soft tissues are attached and where soft tissue spaces are. And so that where exactly the apex of the tooth is in relation to these things will determine how the pus will spread into the greater maxillofacial region. The one thing which is very interesting is that despite the fact that there is obvious infection ongoing in the bone, that in a healthy individual, osteomyelitis, which is inflammation of the bone itself, is quite rare. It only really tends to happen when there is disruption to the blood supply or to other factors affecting bone turnover. So for example, in older patients who've got a more compromised blood supply to their jaws, or if a patient has had radiotherapy, or in other cases, if patients have been on medications which modify the function of osteoclasts, such as bisphosphonates, in that circumstance you can get osteomyelitis, but generally speaking, in a healthy patient, osteomyelitis itself is rare. So here's a little bit of a reprise of the anatomy in terms of where pus might go. And if you just follow this through one at a time, let's take this upper molar for a start. Depending on how close it is to both the maxillary sinus and also to the nasal cavity, you can see the pus may spread here, and then in which case the patient may end up with sinusitis. On the palatal side, you get a swelling on the palatal mucosa, relatively straightforward, and that'll be an intraoral swelling. If it is on the buccal side, however, where the swelling develops depends on how the arrangement of how relation of the root canal tip is in the attachment of buccinator, which you can see here. So if the tip of the root is above buccinator, you'll tend to get the pus extending out into the soft tissues of the face. Whereas if it is below the attachment of buccinator, the swelling will tend to be in the oral cavity on the buccal side of the tooth. Similarly, for lower molar teeth, we've got a number of ways in which it can spread, and they are constrained again to some extent by the attachment of muscles. On the lingual side, the muscle which is important is mylohyoid. If it spreads above the attachment of mylohyoid, the swelling will be seen in the mouth. If it is below, well, it extends down into this space here, which is the submandibular space, and that's very significant because eventually the submandibular space communicates with structures surrounding the pharynx, and so that may possibly be a route, if that's affected, of affecting the airway eventually if untreated. Also, if it's below buccinator, you get spread into the face. If it's above buccinator, spread into the mouth with the swelling there. So what about how do they look in practice? Well, here's an example here of a swelling on the palate. This is an intraoral swelling. It's an alveolar abscess, and you can see that the swelling has, in this case, spread with quite a dramatic effect on the palate. Here's another intraoral swelling relating to some lower incisors. In this case, perhaps the muscle attachment in question is that of orbicularis, and the pus is draining above that attachment, so we see that as a swelling in the mouth. And this appearance with these little almost like beads of pus on that is indicative that this swelling is actually about to discharge, and this may well become a sinus, a chronic alveolar abscess. However, if the pus spreads into the soft tissue spaces of the face, well, then you get cellulitis. And in this case, this is swollen. This child with a swollen face, you can see the swelling is largely centered around the lower part of the cheek. It's not spread into the submandibular space, but we've got swelling on the face here. So it's probably come a little bit below the attachment of buccinator. As far as the sinus is concerned, again, just a little reprise of anatomy in relation to that. And you can see in this radiograph here just how close the tip of the roots are into the maxillary sinus. Just a very thin shell of bone in the histology. So it can be fairly common for the infection to drain into the maxillary sinus. And the patient will present with the signs and symptoms of sinusitis. Here's another example, and this time in relation to an upper central incisor. We can see the pus is draining into the soft tissues of the face in the area just under the eye. It's related to this non-vital central incisor here. And even at times we get it, and this is an example of very similar to the one earlier with the chronic abscess, which may well drain within the mouth. Here, it's the draining point is below the attachment of the muscles of facial expression, and so we're getting a draining sinus actually onto the chin, onto the facial skin. This can be significant. The one point when we have a look at where cellulitis can raise a particular problem is, as I indicated, in the submandibular space. And the oral surgeons will talk a little bit about this later on in the course. But it's the one point where if you happen to end up working as a maxillofacial DCT at some point in the future, you may well end up admitting patients for treatment because of the potential of compromise to their airway from infection. And that's particularly when it affects the submandibular space. So that's the acute side. What about the chronic side, the asymptomatic lesions? There are two main lesions here, which is a periapical granuloma and a radicular cyst. And between them, they play quite a large part in the pathology that we deal with and we report on a day-to-day basis in our diagnostic service. So when we had a look back through our biopsies over quite a long period of time, you can see that in fact there were a large number of apical cysts and granulomas, 6,000 of them over that period, which is a significant proportion of all the lesions. And we can see more oral mucosal lesions, but still see quite a lot of periapical pathology. So when you go back to having a look at a radiograph and a histological image like this, you can see, looking at, here is obviously a central incisor, which has got a large cavity in it. It's affecting the pulp then it's become necrotic, and there is this large area of loss of bone, which is associated with the apex of the tooth. Now this loss of bone is a radiolucency. You can see it looks as if it is continuous with the periodontal ligament space, so it's really just quite nicely associated with that periapical space. And it looks also as if there might actually be a little bit of root resorption, which you sometimes see in these lesions. Histologically here, we've got a lesion which looks as if it's beginning to break down in the center. So this is a point of just about the transition point between a periapical granuloma and a radicular cyst. But this space, which it looks like here, this radiolucency, is filled in with tissue. And we're going to have a look at that tissue of chronic periapical periodontitis and see what that entails. So initially what happens is that once the periapical periodontitis becomes established, that there is a tendency towards bone resorption, and that area of bone resorption is infilled by inflamed fibrous connective tissue. And we call that fibrous connective tissue a periapical granuloma. And it's a consequence of a chronic inflammatory process, the resorption of the bone, and an attempt by the body to try and heal this by laying down granulation tissue in this area. Very often it has a fibrous capsule, that is, it's separated from the surrounding bone by an area of relatively uninflamed fibrous connective tissue. But the main part of it consists of granulation tissue, fibroblasts, extracellular matrix, blood vessels, and intermixed within that are a lot of inflammatory cells, macrophages, lymphocytes, plasma cells, and in fact even occasionally neutrophils, even though it is a chronic inflammatory process. The neutrophils are there because, remember I said at some time the balance may be tipped and it becomes acute and the patient ends up developing an abscess within their periapical granuloma. And so that is an ongoing dynamic process. The other thing which is important is this brings us back to our cell rests of Malassez, these little islands of epithelium. And because of the inflammatory mediators which are present, that epithelium will start to grow and divide, as you can see here. And eventually there can be so much of it that the islands of epithelium will break down in the center, and that's the starting point of a cyst, which is where we're heading to next. Round the periphery associated with the fibrous capsule will be osteoclasts, which are indicative of the fact that there is ongoing bone resorption in this area. And just to remember, there is this, or can be this, shuttling back and forward between acute and chronic lesions. Periapical granuloma, which may be asymptomatic, may, for whatever reason, perhaps the patient gets a cold, something which tips the balance, or a blow to the tooth, which makes the bacteria have more bacteria within the periapical space, whatever it may be. And you may get an acute apical abscess, an acute alveolar abscess in a periapical granuloma. And then similarly, it might settle down again. If a periapical granuloma is left for a period of time, it can then progress on to becoming a radicular cyst. Remember, you don't get a radicular cyst without having had a periapical granuloma first. And so this brings us to a subject which we're going to take on in a lot more detail later on in the course, which is the cysts of the jaws. And there we split them into inflammatory cysts and developmental cysts. The developmental cysts are just there for completion. You don't really need to pay any attention to that until the later part of the course. But the inflammatory ones are really quite important because they're by far the most common. And radicular cyst, which is a cyst associated with the root of the tooth, is by far the most common of these cysts. And as indicated, the cell rests of Malassez are important because they are the source of epithelium that gives rise to the lining of the cyst. And so a radicular cyst develops in the periodontal ligament space from the cell rests of Malassez as a result of inflammation following death of the pulp. And so you go through that whole process of pulp death, periapical periodontitis, the development of a periapical granuloma, and the radicular cyst develops within that, as you can see in this picture here. Here we have our periapical granuloma associated with the apex of this tooth. The epithelium is beginning to grow and divide within that. It proliferates to such an extent that it begins to break down in the center, and the end result is the formation of a cyst, which is a fluid-filled lesion at the apex of the tooth. You don't have to get this absolutely at the apex because it depends where the apical foramen opens. In most cases it is, as you can see here, an apical radicular cyst. But if the main or a main opening of the root canal system is on the lateral aspect of the tooth, well then you can get a lateral radicular cyst. On occasions, when the tooth is extracted, but the cyst is not removed, and then it's left to heal, you can get what is called a residual cyst. And so this is just a radicular cyst which is still there after the extraction of the associated tooth. Now, that may still continue to grow and expand because of the tendency of cysts want to accumulate fluid. Just because the main inflammatory driver is removed, that is the tooth removed, doesn't mean that the cyst will just disappear. Even a residual cyst can continue to grow and expand. So here's another couple of radiographic appearances. We have this tooth here, which has got a post crown in it. And you can see if you follow up the lamina dura, there is this radiolucency which is associated with the apical space of this tooth. So it might be a little indistinct resorption perhaps at the apex of the tooth here. And here is another example here again of another post-crown tooth, and it also has a radiolucency associated with the apex of the tooth. In this case, it's much less well defined, and that can be a useful pointer to the fact that there is ongoing inflammation, perhaps acute inflammation within this cyst, and it tends to be a bit more symptomatic. And the symptomatic ones will be less well defined than those which are clinically silent. When you have a look at a gross example, and again you can see here's an extracted lower molar tooth which has come out with the apical pathology on both roots. When you have a look at the distal root, this is a periapical granuloma, a little mass of granulation tissue in the apex. Whereas on the mesial root, it looks as if it's collapsed. That is because it has had a fluid-filled space, and that is a radicular cyst. And so we take the radiographic appearance and look at the histology. In fact, that's what you get. We have a lesion which is attached to the tip of this root, which has got a space in it, which would have fluid in it, perhaps also some cellular debris, and then there is the lining and the wall of the cyst. Sometimes in these lesions which have been standing for a long period of time, the contents are not fluid, they can be semi-fluid material. And see, for example, here, which has been taken out with these two roots, it looks as if the cyst contents have probably been reasonably solid, or at least semi-solid. And so when we come to think of the histology of a cyst, and this is true for any cyst, not just a radicular cyst, you have these three components. You have a lumen, so that is where the fluid or semi-fluid, which is the contents of the cyst, will be. Then there's a lining. And a radicular cyst is lined by epithelium, which has arisen from the cell rest of Malassez. And then there is a wall to the cyst, and it's inflamed fibrous connective tissue, essentially is the remnants of the periapical granuloma. And every cyst has these three components. The lining is not always epithelium, but every cyst will have a lumen, a lining, and a wall. So when we have a look at the inflammation, as you can see here, the histology of the lining. Here is epithelium. It's got a very complex hyperplastic pattern to it. We call that sometimes an arcaded pattern, but it is stratified squamous epithelium. It's non-keratinizing, and associated with it is a lot of inflamed fibrous connective tissue, a lot of dilated blood vessels, as you can see here. When you have a look in greater detail at the lining, which is here, and the wall, you can see the extent of inflammation, and in many cases it is dominated by chronic inflammatory cells because it is a chronic inflammatory process, and so mostly lymphocytes and plasma cells. Another thing which is very common in radicular cysts is this phenomenon which is known as cholesterol clefts. When cysts form, there's a lot of cell breakdown, which means there's a lot of cell membranes to get rid of, and the cell membranes are full of cholesterol. And that cholesterol crystallizes out in the tissues. And so when we process a radicular cyst specimen, the cholesterol dissolves out. And so it's these spaces we call cholesterol clefts are left by the dissolving of the cholesterol crystals. If you were to take some cyst fluid and have a look at it under polarized light, you will be able to see these crystals floating within the fluid. Sometimes the cyst fluid has got a very kind of shiny appearance to it, and that's because of the cholesterol crystals. So that's the inflammatory part of periapical periodontitis, both in terms of acute inflammation and how that may end up in cellulitis and be very significant for the overall health of the patient, and also the chronic processes, which you will spend a good bit of time dealing with in terms of your endodontic treatment of teeth for those of you who are on the BDS course.